Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
TVEC IPI.
Hi everybody, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we're going to be talking a little bit more about TVEC plus checkpoint inhibition, particularly IPI. And I guess one of the interesting questions is going to be, does it look similar to anti-PD-1 as per Master Key 265? But before we do that, maybe a couple of warm-up questions, Sapna. So let's do an easy one first. Why did you become a medical oncologist?
That's not a quick fire question. Let me give you just a very, very nugget soundbite. It is because of Dr. Dennie Jones, who was an incredible teacher in my medical school. Just showed me what real compassion looks like. Lung cancer doctor. He went on to be, I think, the deputy cancer center at University of Kentucky. MD Anderson trained. He was down at my medical school down in Galveston. Lung cancer clinic. This was in the early 2000s. All to say the therapy was, chemotherapy. There wasn't even targeted therapy back then. And I would see him say things to patients like, I'm so sorry the treatment stopped working. The cancer has spread to your brain. There's nothing more we can do. And every one of these visits ended with patients and their families wrapping their arms around him and hugging him and thanking him. And the long and the short of it, one day I said to him, I can't process what's happening. I hear you telling them bad news and I see them responding with a lot of gratitude. And he said that's the beauty of, cancer patients, the grace that they have. Anyway, that's a medium answer, but Dennie Jones is really the guy who inspired me. Yeah. So Dennie, if you're listening out there.
Yeah, that was beautiful. I'm glad I asked you that because it wasn't in the script, but it's more fun sometimes to do things that aren't in the script. And I don't think we can follow that. I have got another sort of question I was going to ask you, but I'll save that for another time, I think. Okay. So let's dive straight in. And I guess the study is a study published in Journal of Immunotherapy for Cancer. In the last year or two, Jason Chesney's the first author, and basically it's IPI plus minus TVEC. So Sapna, take us through it.
Yeah, and actually this is not that contemporary a study. It maybe speaks to sometimes how long it takes us to publish good works. Actually, this came up on our SWOG call on Friday. There is a study back from 2008 or 2009 that needs to be published. The drug has been discontinued and so forth. But these centers did this cooperative group, study and came together to do it. We at least need to publish it. It goes to our conversation we've had multiple times about publishing negative studies. We also just need to publish the studies that we were able to finish, and so anyway, that one's still sitting on the shelf. Yikes, 15 plus years later, I'm going to try to get that one published. But this one, and the reason I say it is it sort of comes up with the demographic. So this is TVEC in combination with IPI versus IPI alone. I do think there might have been an earlier publication on this, but the 5-year final analysis, like you said, was published just last year, 2023 in JITC. And this was a 1-to-1 randomized trial of TVEC plus IPI, 98 patients, or IPI alone, 100 patients. So rather modest, but right in line with where we see randomized phase 2 studies. So just under 200 patients. And essentially these patients were randomized to, TVEC. We'll probably have to put it in the fact check what the dose was, or the schedule. I suspect it's the schedule we're familiar with, the test dose, as they call it, the 10 to the 6 plaque forming units, and then 3 weeks later, 10 to the 8th, and then every 2 weeks thereafter. But in case somewhere along the way it changed, we can fact check that. It was originally designed to be a study looking at PD-1 naive, treatment naive patients, altogether treatment naive. So it's IPI for treatment naive versus IPI TVEC for treatment naive. But as the study was being designed, and maybe we can confirm the dates of this at some point, but when this study was being designed and enrolled, they amended it to make sure it included more modern therapies. They recognize that patients would have potentially access to checkpoint inhibitor and or BRAF targeted therapy. So they allowed 1 line of therapy for BRAF wild type and 2 lines of prior therapy for BRAF mutant patients. But if we look at the demographics table 1 here, is it table 1? It's not table 1. It's a supplementary table. It's in a prior publication, the demographics table. What you see is actually 20% or less had prior therapy. So then it really turns back into a treatment naive study. So this is a majority treatment naive study. And the primary endpoint here, I'm hesitating because I don't even remember now. Primary endpoint, investigator assessed objective response rate confirmed. So it has to be that, response that is confirmed at least 4 weeks later. And then secondary endpoints are all the other efficacy endpoints, disease control, duration of response, progression-free survival, et cetera. So objective response rate was their primary endpoint. And what they found in this study is that essentially this was a positive study for that primary endpoint of objective response rate. It was, PFS, they're describing it's descriptive only. It does not have a significant signal for progression-free survival, 0.14. And then this publication in particular describes the overall survival. So let's see, it looks like the median overall survival was 84.9 months in the combination and 50.1 with ipilimumab alone. So again, descriptive here, not the primary endpoint, p-value of 0.37. So also not a significant p-value with the confidence interval that crosses 1 for both of those. So I guess the top line takeaway here is that TVEC in combination with IPI did seem to improve objective, durable, objective response rates versus IPI alone, but does not confer necessarily a PFS or OS benefit.
Yeah, so what do you make of this? I mean, in comparison, let's start with the Master Q265. I guess a lot of people would have hoped and almost assumed that Master Q265 would have been positive, but it wasn't. But actually, it's difficult to look at this and think there isn't something there, really.
Yeah, I mean, you kind of we've talked about it briefly, but both of these studies were essentially a treatment naive population. So you'd like to be able to say, can we compare these, et cetera? We should look at that LDH in a bit more detail, because obviously the ipilimumab trials look at upper limit of LDH, and the Master Key had a portion of those with upper limit of LDH, but a different cutoff than, say, the Optum trial used. So if I'm looking at these treatment naive studies, there's no real benefit in adding pembrolizumab to TVEC, but this study suggests there is a benefit in adding CTLA-4. I mean, one way to think about it is that could reflect biology. It may ultimately just come down to patient population that was enrolled, but it could reflect the biology in that when you're injecting intralesionally, it's GM-CSF, you're recruiting the immune system. That immune system, those activated T cells, as they're locking into antigen-presenting cells, the first checkpoint that will come up to shut down that early response is CTLA-4. So all the anti-PD-1 in the world may not stop the shutdown of the immune system that's happening with CTLA-4. And maybe that's why anti-CTLA-4 confers a bit of a benefit, because you're actually blocking that first checkpoint. Maybe there's some, rationale here to thinking that even Ipi-Nivo might work, or sequential Ipi and then, PD-1 blockade after those T cells have trafficked over to, say, distant areas, lymph nodes or tumor sites. I don't know. I mean, my take is it could represent biology. It could just represent where we were at the time in the landscape with minimal prior therapy. I think the real question is if you have this patient, maybe you, James, if you have this patient in the UK, are you combining TVEC with any checkpoint inhibitors, or you're routinely just giving TVEC as a standalone?
Yeah, we can only do it as a standalone in terms
So
of
that's
actually reimbursement and label, in fact. In
yeah,
fact, our reimbursement's fairly strict, so really you can only give it, in general at least, in someone who's had a checkpoint inhibitor already.
I
But,
see.
quite often what one might do, and I think we talked about this a bit before, is if you've got someone who's had checkpoint inhibitor, and they'll have quite often had Ipi/Nivo, and they progress straight through. We might be using it in that setting where they maybe do already have some, or still have some checkpoint inhibition on board. So I was just actually looking at it's not on the PDF of the 5-year paper. It's a bit of a shame, I have to say, that the baseline characteristics, at least as
Demographics.
far as I can see. Yeah, I mean, obviously they've been published before, but I have to say, if you're going to this paper for the first time, you'd really want to see that. But anyway, it's not there. But actually, when you were talking about LDH, I was just looking at that, and most of the patients actually got normal LDH. And if you look at the forest plot by LDH, actually, for the ones who did have high LDH, doesn't really look like the experimental arm got much benefit. Whereas in the normal LDH, below upper limit of normal, it looks like that's the group of patients, who are getting benefit. For what that's worth, subgroup, small study, all that sort of stuff. But I suppose I was going to ask, I mean, do you think this is now the boat's sailed? It's a kind of a bit of a historical footnote. Things have moved on, or do you think there might be scope for a bigger trial? There's something really going on here in the biology that we need to know about, and we've sort of, missed, as it were.
Yeah, I mean, I don't know if you and I have actually had a discussion on this. Maybe it's worth having. This is for a treat frontline patient population. I do kind of think the boat has sailed here. We have such strong systemic frontline options. I guess maybe you could say there's a patient population because the side effect profile is so consistent with checkpoint inhibitor here. There might be a patient population where you just want intralesional as your frontline, but that's going to be pretty rare. But the one that you and I may not have yet discussed is actually neoadjuvant TVEC. Maybe there's a role for intralesional or, doing this when you still have operable tumor. Perhaps all the things we're dancing around is that these TVEC studies, Master Key, TVEC alone, and TVEC with IPI, are also enrolling patients who really just have visceral disease and an LDH, where ultimately we want to give them good systemic therapy. But we'd like to extinguish this systemic disease, not just the injectable. And that, I think we would agree, the systemic therapies are there. We're there with combination checkpoints. So I'm not sure anybody's reaching for TVEC in these sort of treatment naive frontline situations. What do you think?
No, I think that's those points are all well taken. I mean, I was just thinking when you're talking about it a little bit about neoadjuvant, though, and I guess for the purposes of the future, we have to say that Nadine is going to be presented at ASCO quite soon now. So the kind of the data on out in the public domain. But then I thought to myself, well, that's an interesting idea, using TVEC in the neoadjuvant setting. But then does that mean you need a bit of anti-CTLA-4 on board as well, or not? Because you can imagine, I'm just thinking about contribution of components now.
Yeah,
So
I mean, it almost sets us up to, well, we should talk about it in a future podcast, the Reinhardt Doomer TVEC neoadjuvant study, and then where to go with that, because that was a study that was not run in the UK or the US. Maybe there is a follow-up to be done there, and maybe let's see what Nadina tells us. Maybe we'll figure out a way to do a randomized trial.
Yeah.
Good.
Okay. Any other points on that? Do you think we've got everything?
I think we got it. I don't know if we talked efficacy. We didn't really talk toxicity, but we've talked toxicity about these intralesionals, nothing major. pretty comparable between the two, nothing new or additive. And, you know, in the US, I think people are on the basis of this randomized phase 2. If they're using TVEC, they're considering adding IPI, or you could consider. Insurance might initially say, show me the data, but you have it here. You have this publication now. You have a couple of publications on this. This was the 5-year survival. So it's a reasonable option.
Okay, thanks. It was a nice discussion. So we'll wrap up there.
All right. Okay, fact check for our TVEC IPI study. I was just hesitating about the dose or the schedule. So this is TVEC at 10 to the 6th plaque-forming units, week 1, and then 3 weeks later, at week 4, it's 10 to the 8th. So that's that maintenance dose. The 10 to the 6th is a test dose. And then it was every 2 weeks thereafter. So 3-week interval between doses 1 and 2, with a test dose followed by the maintenance dose. And then every 2 weeks thereafter. IPI was the standard 3 milligrams per kilogram every 3 weeks for 4 doses. Starting at week 6 is important in the combination arm. I think in the IPI alone arm, it started up front. And then there was no maintenance IPI. And it's just a point probably worth making. This is slightly different than the Master Key 265 dose, which at week 9, the TVEC went back to a Q3 week dosing. So after the week 4 injection here, it stayed at Q2 weeks. Minor point.
Okay, and then the original reference, actually, I think is number 13 in the manuscript, which is GACO 2018, with Chesney as the first author.
Is it number 12 with Puzanov as the first?
No, 12's not randomized.
Oh, okay. Got you. Good.
I realized that while I was looking at it after we'd spoken about it. Yeah, it's 13.
Good, perfect. Good. Well, that's a wrap on our facts then.